Welcome to In the Clinic by Dr. Butch Levy. This month's episode is titled GI System Diseases, Part 3.
Good afternoon. We're picking up the third session of the digestive seminars by including it with an hour related to the GI cancers that are common. It's important to understand that what we've talked about throughout the other seminars, we've talked about gastric problems with reflux and heartburn and indigestion. We've talked about SIBO, talked about gallbladder disease. We've talked about chronic diarrhea, constipation. The important thing to recognize is that it's all kind of different involvement of the gut for an extended period, or the intensity of the pain or the amount of diarrhea. Oftentimes people live with the things we've discussed. But it's also important to understand that GI cancers can present in the same way with the same symptoms. And so it's important to always have in the back of your mind that while it's common for us to treat these problems in Chinese medicine, that if you find that there's something intuitively that doesn't fit, or the symptom seems out of proportion, especially things like weight loss, decreased appetite. In the Chinese model, people say that recognizing cancer with the pulse is very different, and it seems to be limited because the body does not recognize that the cancer is really something different than part of the body. So the pulse is a little less reliable. Certainly weight loss, certainly loss of appetite, but also if people that have sudden changes in their vision is always considered a concern. And when you look at the white areas in the cuticles of the nails on the fingers, the moons, the less moons that you have, the greater the risk it appears to have a cancer going on. So don't become too passive about thinking that what you're treating is just a run-of-the-mill symptomatic thing. Always keep in the back of your mind, especially in people that are older, it doesn't hurt to have people evaluated to make sure that what you're dealing with is truly something that should be dealt with from a Chinese perspective. So that's just a good way of acknowledging that these different problems can occur presenting with the same symptoms. So we're going to talk about colon cancer first. Obviously, it's the ascending, transverse, descending colon with the rectum. And how you look at rectal cancer is somewhat separate than how you deal with it with cancer in the colon itself, in the ascending or descending colon. So locally, it's different, but as the disease progresses, the types of treatments that are available become the same. And it occurs in those folds and crypts, as they're called, in the epithelial layer, where you get a growth of cells, and you start with a polyp, and the polyp starts enlarging and becomes an issue. Most of the time, the things that we see as the predominant sources of colon cancer etiology are usually related to polyps. And it's the goal of doing colonoscopies to find these adenomatous polyps that can become a concern, because most of the time you try to remove them and biopsy them and at least know what they are. But there are definitely relationships between genetic mutations, family histories. There is often a 20% risk of having colon cancer. So as you probably already know, if you have a family history, you should be doing colonoscopies 10 years earlier than the average time that they're recommended, which would be somewhere now between 45 and 50. Inflammatory bowel disease raises that risk. So your patients with ulcerative colitis and Crohn's, again, chronic inflammatory problem, and inflammation damages cells by creating oxidative stress, which can injure cell reproduction and DNA. There's no question that low vitamin D levels, which is much more of an immune protector as opposed to necessarily be related to bone protection, but it's very important to have vitamin D levels somewhere in the mid to upper 50s. So the other mutations that you see, Ashkenazi Jews have about a 6% risk, but the most common one that I have seen now, a number of cases, has been what's called Lynch syndrome. And Lynch syndrome is a hereditary family background of cancer that you often will see it with colon cancer, but you can also see it occurring with uterus, ovary, hepatobiliary, urinary tract, brain. All of those things all can be associated with Lynch. In fact, the last patient I had that had colon cancer, when the genetic testing was done, the patient had Lynch syndrome, and because she'd had colon cancer, she had her uterus and ovary removed, ovaries to reduce the risk of having that in terms of concern later in life. I think the other things that you see as risk factors for colon cancer are diabetes, and you also can see it with people that have no intake of fiber in their diets. I mean, the goal being that if you have enough fiber, you're obviously going to have regular bowel movements, so you're not exposed to the toxins that we receive in the gut. So obviously, the risk of foods like high fats and red and processed meats, most of the time it's the nitrites that are in the meats that are concerning. So processed meats, there's a concern about red meats, but again, those people also eat a lot of red meat that probably indicates they get a source that isn't necessarily as clean as they would like. But supposedly high-fat diets, and again, I think trans fats are probably the major issue here. I don't think there's anything with having correct fats in the diet. So as you can see, 90% of colon cancer is over the age of 50. However, what we're seeing now is that there is a lowering of the age that people are starting to get colon cancer. So again, it's really a screen, and it's important that if there's a family history or a risk that you think the patient might have, then doing a colonoscopy, the prep is worse than the colonoscopy. It's worth, as a preventive thing, one of the more important things. There also is a group that get colon cancer in their early 30s, and a third of these are related to some kind of genetic hereditary thing. But more than likely, it's that while they have a hereditary aspect, there's probably epigenetic or messaging that's going to the genes that are causing this, that are impacted by diet and toxins. So while it's easy to say it's all heredity, there have to be triggers to that heredity. So diet becomes a very important aspect.
We hope you found this training helpful. To continue watching this training and others, please visit eastwestmedicaleducation.com and click on the tab In the Clinic to subscribe.